All right, good morning, everyone. And when I was looking for a grand round speaker, I wanted somebody to speak on this topic because it's the question I get the most often from general pediatricians. I get a lot of calls about HSP. And it's also one of the topics where we have our longest conversations within the nephrology group about what to do with these patients when they come up, because nobody really knows the right answer. So with that, Dr. Louise Oni is going to be our speaker today, and I'm very pleased to have her here. She is a senior lecturer in pediatric nephrology and honorary pediatric nephrologist at Alder Children's NHS Foundation Trust Hospital in Liverpool. She got her medical degree at the University of Liverpool and then went on to get a master's in medical ethics and law and a PhD at the University of Liverpool as well. She has founded the IgA vasculitis study at her current institution, where she's collecting biosamples and hoping to learn more about this important disease in children. So with that, Dr. Oni, I'm very much looking forward to your talk.
Thank you. Thank you for the introductions. Yes, I'm Louise Oni, a paediatric nephrologist based in Liverpool in the United Kingdom, and I'm going to talk about updates on IgA vasculitis in children, or Henoch-Schönlein purpura. So just to have a disclosure slide, I have nothing to disclose. So first of all, as mentioned, one of the very few positive things to come out of the last year is the fact that I'm able to present from Liverpool in the United Kingdom to an audience such as yourself without any jet lag, any cost, or any kind of missing time. So I just thought I'd give you a little bit of insight into our hospital, which is actually one of the oldest children's hospitals in the United Kingdom. And you can see here what our old hospital used to be like, and it was a pre-war building, and during the war period was used to house injured people and then sick children, and then became a children's hospital. And what you can see is that this piece of land here, which was Parkside, next to our old hospital, we borrowed about 5 years ago and built a really new state-of-the-art, fantastic hospital. And the old hospital has since been demolished, and we've given the parkland back to the local residents. And so we now have this state-of-the-art children's hospital, which was designed by children and features every single room looking out onto parkland, which is what children felt would make them feel better when they're unwell. And so we have this fantastic hospital in Liverpool, where I'm based. And I have an interest in renal inflammatory diseases in children, and I work as part of a group of core clinical academics in what's called the Experimental Arthritis Treatment Centre for Children. And this is the UK's only experimental treatment centre for inflammatory diseases in children. And what I found when I was previously doing my research in children who had lupus nephritis is that I had a control group of children who had IgA vasculitis, or Henoch-Schönlein purpura. And whenever I presented this group of children, which was focused on lupus nephritis, the audience was much more interested in HSP, and it got so much so that peer reviewers in papers would ask me to take that cohort out because it was very distracting. And I realized then that there was a huge unmet need in this condition, from both a biological but also from a clinical way that we manage children. And I've gone on, which we'll touch on at the end of the presentation, to develop a translational research group looking at children with IgA vasculitis linked in with the EATC for children. So over the next kind of 40 minutes, I'm going to cover more about the background of IgA vasculitis, how it might clinically present, touch a little bit about the pathophysiology of IgA vasculitis, and then focus on its complications and management, most of which involve the renal system. And then I'll finish just by talking about some knowledge gaps and areas for future research. And as you've probably heard us talking, the name IgA vasculitis came about a few years ago when different types of vasculitis were renamed to better reflect the biology that they might be representing. And so what was traditionally called Henoch-Schönlein purpura is now often used and called IgA vasculitis, but in real terms, the two names are used interchangeably, and you'll probably hear me using them interchangeably throughout the talk. So HSP or IgA vasculitis are interchangeable at this present time. So IgA vasculitis is a form of an autoimmune type of vasculitis that fits within the small vessel category if you categorize different types of vasculitis. And you can see here all of the other different types of vasculitis that we may come across in pediatric disease. What we see with IgA vasculitis is that 70% of the disease will present in children, and 30% will be in adults. So it is predominantly a pediatric disease. And we see a very slight male predominance with the male to female ratio of 1.5 to 1, which is fairly similar in the adult population too. And if you look here at a graph with the age of presentation, and this was a large epidemiological study which looked at different inflammatory diseases in children, you can see this top line here is HSP, and we can see the peak age of incidence is around about 6 to 8 years. So this is a disease that predominantly affects the primary school age children, but it can affect children of any age going on into adulthood, as you can see here. So if we look at these pie charts comparing children with vasculitis compared to adults with vasculitis, you can see here by this diagram that if you look at all the different categories of vasculitis, then HSP is by far the most common type of vasculitis in children. And this is in stark contrast to adult disease, where if you look at this section here, you can see that the small proportion here is adults. Let me just see if I can move that. Is adult HSP. And so adults are less likely to come across HSP, and it's less likely to be a big part of their workload compared to pediatricians, who I'm sure most of you will be familiar with this disease. So how does it present? What we see characteristically is 95% of the patients will present with a rash. The other 5% will often present with abdominal involvement, and then the rash will come on subsequently. And this rash presents symmetrically and is described as a palpable purpuric rash, which often has petechiae in areas of bruising, and very rarely will have necrosis or areas of blistering. And you can see here on this picture illustrating it, that it's often symmetrical. It usually starts on the lower limbs and progresses up, sometimes up to the buttocks. Very rarely presents on the face, less commonly on the trunk, and can present on the arms as well as the limbs. And this skin involvement is often then combined with other organs being involved, and this includes the joints, the gut, and the kidneys. And so we see musculoskeletal involvement in about 70% of children when they present, and this is usually a non-erosive arthritis, or more typically just arthralgia, which is usually associated in the areas where the rash is most predominant. GI involvement is fairly common. Up to 70% of patients will have some involvement, and this can be a spectrum of abdominal pain right through to more severe acute GI bleeding and even intussusception. Nephritis is also common in 20 to 60% of patients, and again, this can present as a spectrum of either microscopic urine abnormalities right through to rapidly progressive glomerulonephritis. In the boys, you can see orchiditis. And extremely rarely in children can you get neurological involvement, and this might present with seizures or lung involvement presenting as pulmonary hemorrhages. Now, these would be really atypical disease and unusual, but are slightly more common in the adult population. So there are internationally agreed classification criteria for HSP to distinguish HSP from other types of vasculitis. And you will see that most of these involve clinical symptoms or signs that form part of this classification criteria. And so the mandatory criteria is the presence of this purpuric rash, which is predominant on the lower limbs and is not related to thrombocytopenia, so patients would need a full blood count to exclude that, together with another feature that can either be abdominal pain, the histological evidence of IgA, either in the skin or the kidneys, arthritis or arthralgia, or renal involvement. And this, having a rash together with any one of those features, gives a really good sensitivity and specificity of distinguishing it from other types of vasculitis. And so the diagnosis of HSP is mainly made through clinical features that are found in the everyday setting. When we look at IgA vasculitis, we do see seasonal variation, and so therefore there may be triggers that promote the onset of this disease. And this is a graph here from a paper in Japan, where they looked at the number of HSP patients and they looked at the seasonal variation over a year. And you can see the different months of the year here with the different trends in the incidence, with a lower incidence during the summer periods and higher during the kind of spring and winter periods. And what they did was they correlated the incidence of IgA vasculitis with specific respiratory and enteric viruses. And unsurprisingly, really, most of the viruses were found to potentially be associated with the onset of IgA vasculitis. And these viruses changed with the different ages of the children. And so you could see that the early childhood were more likely to have RSV and influenza as a trigger for IgA vasculitis. And then the older children were more likely to have conditions such as rotavirus. And these are very typical viruses that we see in childhood populations anyway. And what's interesting is back when this was published, no one probably even batted an eyelid at coronavirus, but you can see even in this paper that the coronavirus strain, it can be a trigger for IgA vasculitis, and that was found significant in early and middle childhood. And so it's not surprising that there are reports in the literature of patients who have had coronavirus, particularly adults, who've then gone on to get IgA vasculitis because these viruses are known to be a trigger for this autoimmune process. Other triggers include ENT infections, and quite commonly patients would have had rhinosinusitis or otitis media or tonsillitis preceding the onset of IgA vasculitis. And interestingly, a third of patients in a large cohort were seen to have recurrent streptococcal tonsillitis in their past medical history. And this is worth exploring when you have a patient perhaps who has a more atypical or persisting disease. Poor dental hygiene is also seen, and in one report this was fairly common, with dental caries seen in up to 70% and periodontitis seen in over 50%. And this is something that we've more recently been starting to pay attention to in my centre to try and see whether this could potentially be a trigger, because the dental hygiene is not as good as it should be in some of our children. And less commonly perhaps in paediatrics and more commonly in the adult literature is certain drugs and vaccines as being a trigger for the onset of IgA vasculitis, but this isn't something that we necessarily see in paediatrics. So what's happening in IgA vasculitis? Well, as the new name suggests, it's thought to arise from the IgA molecule, and we know that immunoglobulin A is present in our mucosal secretions, and it's the first line of defense against invading pathogens. So it's your immediate immune response if you have an oral or ENT infection, and your IgA is present in the mucosa in your oral cavity and also right through your gut. And what's thought to happen in this disease is that the IgA that's actually produced in response to this trigger, so viral infection or ENT infection, is actually in an abnormal version. And this abnormal version then causes the immune system to promote antibodies against it. And what we see is circulating IgA immune complexes, often with IgG, and also the abnormal IgA itself in the circulation. And these are then resistant to being cleared away by normal pathogenic mechanisms. And we see that these can bind to the endothelial cells and can accumulate in the small vessels that we characteristically see present the features that I've described. And within the histology, we see the IgA deposited in the vessels, but it's often accompanied by complement C3 and numerous inflammatory cells. And these produce the leukocytoclastic vasculitis that we know as HSP and cause the symptoms arising from the vasodilatation, the blood vessels leaking. So just to look more closely at the IgA molecule, here is immunoglobulin A, and the abnormal area within this IgA is believed to be in this hinge region just here. And it's meant to be a small number of this region that has abnormal glycosylation in the way that it's been formed or produced. And what's believed in the literature to happen from very small amounts of scientific data and also derived from data from IgA nephropathy that may or may not be on the spectrum of IgA vasculitis is that there are residues that then, from this abnormal pattern of glycosylation, there are residues exposed that then constitute an antigen to the immune system. And so there's been theory that a GalNAc residue is then exposed and can specifically bind to some of the receptors within the mesangial cells, which are placed within the kidney. And so it may be that this pattern of glycosylation exposes certain areas that are then able to bind to certain organs within the body and that produce the phenotype of the disease. So what about the outcome of this disease? What happens to the patients when they present with this disease? Well, in the majority of children, it's an acute illness lasting less than a month, and most of them will have an excellent outcome. So by 30 days, 70% would have made a complete and absolute recovery. And by 2 years, 94% would have made a complete and absolute recovery. And this is different to other types of vasculitis in children, where we often see a much more chronic disease needing lots of medication. That in HSP, most children have a self-limiting disease, which gets better with time. We do see relapses, and a quarter of patients will have a relapse or have a persisting rash within that first year. And after that first year, it's much less common to go on to have persisting or relapsing disease. And these patients may need further investigations or may need treatment if they went on for a longer period of time to have a persisting course. There is an acute morbidity related to mainly the acute GI involvement, which can cause patients to need hospitalization or might need medication or interventions. And I'll touch on that in the next slide. And in the longer term, the prognosis is mainly related to the presence of nephritis. So just to pick up on the acute GI involvement, I think this is probably an area which, again, has unmet need and can sometimes be under-recognised. We've recently looked at a cohort of our patients, and I think we had 153 children with IgA vasculitis, and we saw that just about 35% of them had abdominal involvement. And of those, the majority had abdominal pain, but we were quite surprised by the number that had vomiting, that 67% had vomiting. A quarter of our patients with GI involvement had GI bleeding, and then 15% had intussusception. And so there's quite a significant pathology even within the group that have acute GI involvement. And when you look in the literature, there's very small reports of patients who have some more severe GI involvement. And this study that looked at 16 atypical cases, so they weren't responding to initial line therapy with steroids and had persisting GI disease. They went on to do endoscopies in this cohort, and you can see that there was significant pathology seen within the gut in this group who had a slightly more severe GI involvement. So I think perhaps there's an under-recognized need of acute severe GI involvement in a proportion of patients that perhaps needs earlier intervention, but we need to understand a bit better. For the renal outcomes, perhaps we know a bit more about this. We see that nephritis presents in the majority of children in that first 6 months. So it's usually during that acute period. And the literature suggests that 97% will present during that first 6 months. And therefore, it's generally recognised that patients should have screening for 6 months after their first presentation to look for any renal involvement through their urine. There is a recognised risk of chronic kidney disease associated with IgA vasculitis, and all stages of chronic kidney disease, that risk is up to 15%. But if you look at CKD stage 5, which is children who have what's called end-stage renal failure, who might need a kidney transplant or dialysis, that risk is about 1 to 2%. And this number, 1 to 2%, is very consistent in the literature and hasn't changed over many, many decades. We do see in longer term follow-up studies that even those who have nephritis go on to have significant ongoing problems in the longer term. And so 20% of patients who have nephritis will go on to have proteinuria at 10 years follow-up. And perhaps therefore we don't know the 20, 30, 40 year follow-up and what might happen to these patients in terms of chronic kidney disease when they go on to live a much longer duration than we have studies that have followed them up for. The poor renal prognostic features at presentation include a low glomerular filtration rate, so patients who might have an elevated creatinine at presentation, children who might present with nephritic syndrome or nephrotic syndrome. And in this group of patients, the risk of chronic kidney disease is up to 50%. So compared to the 5 to 15% of all patients, it really rises significantly in this group. And so you can see here, just to illustrate the renal outcomes, if this is all 100 children with IgA vasculitis and 50 of them would not have any renal involvement, there would then be 30 of them that would develop some nephritis, but that would spontaneously get better. There would be another 18 that might not have nephritis that might need treatment. And there would be this 1 to 2% who would go on to get chronic kidney disease stage 5 that might then need a kidney transplant or dialysis in the future. And so we can see that the difficulty with this condition is trying to filter out this very high risk group from lots of patients who are likely to have a really good outcome and make a complete and full recovery from this disease. So if we look at how we manage IgA vasculitis, and in particular managing the complications, because this is going to get better in the majority of children, there was an internationally based consensus recommendations published about 18 months ago, which were chaired by my colleague in my department, Professor Beresford. And these are the first consensus-based recommendations for this disease, and they really are worth a read if anybody's interested in reading further. And what we see in this document is very detailed recommendations on the diagnosis and potential treatment options for IgA vasculitis that includes all of the organs. And I've just picked apart here some of the more complications that might be recognised. And so we can see here that in patients with IgA vasculitis, if they had more severe skin involvement, such as areas of severe necrosis or bullae or blisters that potentially are at a risk of jeopardizing the skin integrity, then there may be a role for considering a course of corticosteroids in that group. In most patients, though, these will get better with time. With joint involvement, most children, this will be relieved with analgesia and resting, and in those who don't have significant renal involvement, non-steroidal anti-inflammatory drugs can help them. But again, this is usually self-limiting and completely resolves with time. The abdominal involvement, as I mentioned, can be a spectrum, and some patients will just need analgesia and supportive management. But those patients who may go on to get more severe complications, such as acute severe GI bleeding, might need an intervention or further investigations. Patients who have severe abdominal pain needs to be a red flag for interception, and the ultrasound has a good pickup for detecting interception and is recommended in the consensus-based recommendations for IgA vasculitis. And in this group, there's a limited evidence to suggest that there might be benefit from corticosteroids. So from a 2-week course of oral steroids followed by potentially a tapering course to help the acute severe GI manifestations. But at the moment, there isn't any role for the routine use of corticosteroids in those who might have a more milder abdominal involvement. For the kidneys, as I mentioned, it's recommended that all patients should have a period of renal monitoring to pick up and detect nephritis because of that risk of 1 to 2% of developing chronic kidney disease. And so all patients should have a period of 6 months monitoring. And if that urine is normal after 6 months, then they can be discharged with no further follow-up. In patients who may have evidence of nephritis, they might then go on to need further investigations, possibly a renal biopsy, and then consideration of treatment. And this is what we'll touch on in the next few slides. So the kidney management, I mentioned that all children should have screening for 6 months. And we, quite some time ago now, almost a decade ago, presented our 5-year data and our nurse-led pathway that we do in our centre, which actually began to triage patients according to whether their urine was normal or whether they had proteinuria. And so we see patients with proteinuria more frequently than those who have a normal urine, where we see them less frequently. And if their urine's normal after 6 months, we will discharge them. And our nurses have strict criteria on when to refer and get further input and review. And what we found when we looked at our pathway and looked at our data was that this day 7 urine, if you had a normal urine at day 7, it was actually a really good negative predictor of a normal outcome. So it was able to predict, if you had a normal urine at day 7, that you were very likely to have a normal outcome. And the negative predictive ratio was 97%. And reassuringly, a group in Japan have also analysed their data using the similar statistics and found very similar with their day 7 urine. If it was normal, it was a very strong negative predictor that you were going to have a normal renal outcome. And at the moment, this doesn't change practice because we probably need data on a larger number of patients. But in my personal practice, if I had a patient who had a normal urine for the first few visits and then didn't attend perhaps the last visit, then I would maybe just write to them and not necessarily chase them for that last visit, because I would be more confident that they're likely to have a normal outcome. And that's where I think that this data provides some reassurance for patients, and perhaps we are able to tailor this further in the future so that we can just home in and prioritize those who are likely to be at higher risk. So in patients who go on to develop IgA vasculitis with nephritis, so with significant renal involvement, they will need a kidney biopsy, and it's then the histology that the clinical features that will guide treatment, which we'll talk about. So as I mentioned, the SHARE initiative was the first international consensus-based recommendations for IgA vasculitis. And what they did was a number of systematic literature reviews to look at what data and evidence was out there. And then through consensus-based work, the majority of which was done by paediatric rheumatologists with a nominated nephrologist, they developed a number of consensus areas to base some recommendations on. And what we found within the recommendations was that the group came up with when to recommend a renal biopsy. And this was mainly based on the presence of severe proteinuria as being an indication for when a nephrologist should do a renal biopsy. And we were awarded a grant to hold an international workshop where we did a number of different tasks. But part of this workshop, we looked at those biopsy recommendations as a group of expert international nephrologists. And what we did was we tried to incorporate that into more user-friendly language, and language that perhaps might be more translational to other aspects of nephrology, such as the AKI staging. And so we included indications that were similar to the SHARE initiative, which looked at proteinuria, but also included AKI staging and the presence of nephrotic syndrome due to the known risk that this has with long-term outcomes. And then relative indications included severe proteinuria at any time point and a creatinine above the upper limit of normal, which might not meet the criteria as above. And so we essentially use the SHARE criteria to translate these into more usable indications that we felt might be more suitable for a paediatric audience where the majority of the care for this patient is under them. So then we come to the problem with the kidneys of when to treat. And what we know is that if you take all patients here with IgA vasculitis, we watch and wait for 6 months at least to look for the presence of nephritis. And if we looked at all children with IgA vasculitis, regardless of what their urine finding was, and treated them with a course of early corticosteroids, we found from meta-analysis that this makes no difference on the risk of kidney disease subsequently. So there is no evidence to support the routine use of prophylactic steroids in the early stages of IgA vasculitis to prevent the onset of renal inflammation. And this is probably because there's a large cohort of children who are never going to get any nephritis and who are going to make a complete and full recovery no matter what. And so proving that a drug works in this group of children is really, really difficult when you have a large number that are going to get better. So we don't treat patients to prevent the onset of nephritis. What about early nephritis? I talked about how our monitoring pathway splits patients into whether they have any evidence of proteinuria or not. And I think there is a really big role for treatment in this early phase. And we're currently screening our patients and collecting urines through a biobank to look for early markers that we might be able to target in this group of patients, including the complement system, because there may be a role to try and identify at an earlier stage the onset of nephritis. But at the moment, there is no role for early intervention in this group of patients. And so what happens in clinical practice is that we treat patients based on the presence of established nephritis, which has been histologically proven. And large groups such as Cochrane and then replicated by the SHARE initiative have demonstrated that there's very little evidence to support any treatment and benefit from treatment in this group of patients, and mainly because the studies are so small, uncontrolled, and probably underpowered studies, the majority of which are not randomized controlled trials. And so at the moment, the evidence to support how we treat patients is very, very limited. What we do have are 2 recommendations, and this includes the SHARE criteria, like I'll mention, but also the KDIGO International Clinical Practice Guidelines for glomerulonephritis. And what we see with these 2 guidelines is that they're actually slightly different. So the KDIGO guidelines suggest that we treat patients with HSP nephritis as first line with ACE inhibition, and then if they're not responding, we use corticosteroids, and if they had severe, rapidly deteriorating disease, then we might think of stronger treatments such as intravenous cyclophosphamide. And these clinical practice guidelines are really based on adult IgA nephropathy and replicated into HSP nephritis, and not using data that, because of the lack of data specifically for this condition. The SHARE recommendations perhaps better reflect clinical practice in paediatrics, where they categorize patients into mild, moderate, or severe nephritis and suggest the use of corticosteroids together with a second-line immunosuppressive agent, and that could include azathioprine, MMF, or intravenous cyclophosphamide. They suggest ACE inhibitors are used at a later stage if there's persisting proteinuria, and they don't routinely recommend the use of cyclosporin or oral cyclophosphamide. And so we have very contrasting guidelines, and actually when we've done scoping exercises, we see that there are nephrologists who sit on either side of this. Some of them prefer to treat it like IgA nephropathy, and some prefer to treat it more like a vasculitis with immunosuppressive agents. And so what we've done over the last 18 months is a big program of work to try and see what's happening nationally and internationally. And we undertook an audit across the UK to look at the last 3 cases. We called it the last 3 for HSP, the last 3 cases within each paediatric nephrology centre that had a renal biopsy for HSP. And we had 35 patients who were collected over a 2020 retrospectively month period. And what we saw, as you can see here, is this is the number of patients treated. This is the number of different treatment combinations here. And for what was very similar clinical presenting features, we saw a massive variation in treatment with over 15 different treatment regimes in use. And this included patients being treated just with angiotensin inhibition, people just being treated with prednisolone, so corticosteroids, and people being treated with a number of different immunosuppressive agents, so azathioprine, cyclophosphamide, mycophenolate, cyclosporin, tacrolimus, and yeah, I think that includes them all different combinations. And so within the literature, there are also suggestions of alternative treatments. Tacrolimus has been reported in a small pilot study of 20 children where they demonstrated a 60% response rate. And these are similar response rates to any of the other agents, such as mycophenolate. There's also in the literature, plasma exchange has been presented, but again, you begin to see variable outcomes. So this study that looked at 16 children still had 1 that progressed to chronic kidney disease stage 5. The rest had minimal proteinuria or went into complete remission. And another case series that looked at 5 children, and again, 1 of them progressed to dialysis dependence. And you see this common theme that within all of the case series, there are continuing to be a couple of children that will progress to CKD stage 5, regardless really of what treatment seems to be used. There's 1 case study within the literature looking at complement inhibition, where again, the patient had a rapid response to eculizumab, but progressed to chronic kidney disease stage 5 within 2 years anyway. There is perhaps more reassuring evidence for B-cell depletion based on some science that's published for both IgA nephropathy and HSP nephritis, where increased B-cell numbers are seen within the blood. And so there are case series which are slightly larger, looking at rituximab in resistant disease. So this is a cohort of 8 children, again, very tiny numbers when you compare them to other diseases. And these children had corticosteroid dependent disease. And what you see that with the use of rituximab, there was 4 children who only required the 1 course. 4 of them went on to requiring multiple courses in a more kind of dependent on B-cell depletion manner. But of the 8 children, 7 out of 8 went into full remission, and they all reduced their corticosteroid burden. So there may be a role for rituximab and B-cell depletion in this disease, or particularly in children who have more resistant disease to other conventional treatments. And the adult data is very similar, really. So 12 adults with severe IgA vasculitis, nephritis, and crescentic disease. And these all had refractory disease. And with B-cell depletion, what they saw was that 10 out of the 12 had a complete response, one had a partial response, and then one of them required this maintenance rituximab use because of dependence. And again, a slightly smaller adult study when, again, 3 out of 5 who had multi-drug resistant responded, and all of them, apart from one, had required maintenance treatment for relapsing disease. So B-cell depletion may have a role in IgA vasculitis in a similar manner to other types of vasculitis, but at the moment the evidence is continuing to be based on case series and case reports. Other studies have looked at targeting the coagulation system, looking at low molecular weight heparin, and this was probably one of the largest trials in HSP, with 89 patients where they used low molecular weight heparin alongside conventional treatment, and they saw improvement in renal outcomes. And it was believed that inhibition of hyperfibrinolysis may be improving the renal blood supply, but this was offset by the need for daily subcutaneous injections, and it hasn't been replicated. And really, in a disease where some children will have a spontaneous improvement no matter what we give them, it's actually quite hard to justify daily subcutaneous injections when we have very limited evidence to support the use of any of the treatments that we use. There's no evidence to support the use of IVIG, montelukast, urokinase, vitamin E, or fish oil, but again, some of them might have a role if there was very, very severe life-threatening disease, such as IVIG or plasma exchange. There is some small studies looking at eradication of oral infections. Like I mentioned, the oral cavity might be a trigger for the disease. Recurrent tonsillitis or poor dental hygiene could be driving the production of abnormal IgA. And so there may be benefit in a small cohort of patients for tonsillectomy or for improved dental hygiene. And one study demonstrated complete recovery following very aggressive oral management in these patients. But again, these are invasive procedures in a disease which is affecting children, and I think that we need to be tailoring it as to the likely cause that might be triggering the production of IgA. So what's the vision? This is the disease as it stands. We have a condition where the majority will have a good outcome. We have a number of children who will go on to get some involvement of nephritis and might get chronic kidney disease that's perhaps milder. And we have this persisting number of 1 to 2% who will get irreversible end-stage renal failure, no matter what treatments we use at the moment. And at the moment, we have patients when they present who undergo this 6-month period of watching and waiting whilst we wait for their kidneys to demonstrate nephritis, and then we intervene. And ideally, what we want to do is be able to predict, preempt, and prevent this process at this time point, rather than waiting for this poor person to get the chronic kidney disease that's then irreversible. And ultimately, the vision that drives my research group is that we want no child with IgA vasculitis to get chronic kidney disease. And I strongly believe that this is a disease that presents acutely, it presents with a rash and presents before the kidneys are particularly involved, that there should be an opportunity to intervene before nephritis sets in. And so I lead a translational research group looking at this disease as well as other renal inflammatory diseases. And what we do is in our strategy, we look at both within the bench, so within the laboratory, at scientific aspects of the condition, right through to the bedside, and how we can improve patient care in the here and now so that our patients are already benefiting from our research. And so I'm currently involved in leading national guidelines for patient care with this disease so that we can begin to standardize what we do across the UK. We're also looking at how we can perhaps tailor our monitoring even better through personalized care. We're collecting DNA in a national biobank to then begin to look at whether there are genetic predisposition to this disease. I lead the IgA vasculitis study, which is a local biorepository for patients who are recruited to collect serial samples, and we're working with industry to also look at those samples to see whether there are targets, particularly targets in the complement system at an earlier stage than what we're doing at the moment. And so we collect and recruit a biorepository of samples that are used then for biological investigation. And finally, we're trying to look at evidence-based to our treatments. So we desperately need better treatments, but we desperately need to produce a standard of care and also to produce some evidence to support the treatments that we currently use, so that we can then make a platform for potentially new biologic agents that might be able to intervene earlier. And so just to touch on one or two aspects of those, the work that we're doing at the moment, we've just started a Kidney Research UK funded project where we're optimizing a proteomic mass spectrometry techniques to look at exactly at this hinge region and try and look at the glycosylation patterns in this region to see that if different people who have different phenotypes have a different pattern of glycosylation. So do our patients with the renal phenotype have a slightly different pattern that then makes them more likely to have renal binding and problems in the kidney, compared to those who might perhaps have a more predominant gastro involvement or something else. And so we're working with our Centre for Proteomic Research to optimize the mass spectrometry techniques and analyze patient samples and compare them to our clinical cohort, that we then hope in the future might act as an ability to potentially diagnose this condition, but also to try and distinguish apart those who might have a more severe renal phenotype than those who are unlikely to have any renal involvement and might not need any renal monitoring. And our clinical work has looked at trying to develop a clinical trial protocol for patients. And we've done a mixed method approach over the last 18 months, which has included an updated systematic literature review on what treatments are available. We've done a national audit where you saw the huge variation in treatment that we're using at the moment. And from those 15 treatments, we began to use opinion polling and an international workshop to get those treatments down and prioritize into what pediatric nephrologists feel are the best treatments we should be evaluating in a clinical trial and what we should be considering as potential standard of care. And from all of this work over the last 18 months, we've put together a trial protocol, which is undergoing funding submission at the moment. And we've put together a phase 3 adaptive placebo-controlled sequential multiple assignment randomized control trial to evaluate immunosuppressive treatments for IgA vasculitis nephritis. And this will be called the Pinpoint trial if we secure funding. And what's important about this trial is it will be tailored to match those patients who are likely to improve and spontaneously improve, but also to escalate treatment in patients who might have a more severe disease that needs escalating treatment at an earlier point. Finally, we involve patients. It was over about 8 years ago when children told me about the problems with HSP. We do at least annual patient involvement events and engagement events. We have children in the labs prior to the pandemic and when we've moved online, but we've held numerous workshops, events, festivals, stalls, etc., to hear and listen to our patients about what the problems are with this condition, because really they are the ones who dictate and direct our research. And it was patients who told me about this area that they described as the window of opportunity that we have in this disease, which you don't often have in many other conditions, and that we should be using this window of opportunity more than what we were. And this is what's driven and motivated this program of work really in regard to HSP. And patients also told me almost 10 years ago that patient information online was really poor. And a teenager told me that if she Googled HSP, it came up as highly sensitive person. And that's what she believed had been wrong with her for quite some time. And so we work with patients, and we've now got a national repository for patient information called InfoKid, which includes accurate information on HSP and HSP nephritis. And so without working with our patients, we wouldn't really have been able to direct a lot of the research that we're doing at the moment. And this is a really crucial part of the work that we do within our EATC group. So just to finalize, and then I'll happy to take any questions. IgA vasculitis, or Henoch-Schönlein purpura, is the most common type of vasculitis in children, and I'm sure it's a condition that all of the listeners on the call today are familiar with. It has an excellent outcome in the majority of children, but there is this recognized risk of chronic kidney disease, which hasn't changed over decades and decades, and the outcomes really haven't changed. And there's limited evidence to support the management. And I really feel there is a window of opportunity where we might be able to stop the onset of nephritis in this cohort of patients. we desperately need translational research to back up how we manage patients. And we also welcome and need international collaboration, because there's far too much work to do just for one person or for one group. And so we work very closely with people around the world, but we really do welcome that. And ultimately, I strongly believe that no child with IgA vasculitis should progress to get chronic kidney disease. And I hope that we live in a world where eventually we can intervene early, and we won't see that this lands on the nephrologist's doorstep, and we see that this is a condition that stays within paediatrics. So just to finish, thank you, and my contact details are there, and to acknowledge the many people and funders that are involved in this work. And I'd welcome any questions from the panel or from the audience. Thanks.
Thank you very much. That was a fantastic overview. And we have a couple of questions that are popping up in the chat and in the Q&A. So if anybody has any others, go ahead and put them in there, and we'll get to as many as we can here. So the first question is on the slide that shows the correlation with the viral triggers. It looks like the trigger data is correlative, and how can we be sure it's actually the trigger, or if it just happens to be a virus that's circulating at that time of the year?
Yeah, it's very hard with lots of these studies. I mean, they're a large study, and there are the strength with the numbers, but it's very difficult to put two and two together. And most of the viruses that are described, everyone will be familiar with, are very common pediatric viruses, and it's very difficult to put two and two together. But I wonder if the virus triggers some kind of receptors, perhaps toll-like receptors, and they're acting in a similar manner. And there is some molecular mimicry, but I don't know, and it's very hard to put them together. They are just associations, and it's really just worth noting in the history any preceding potential triggers. But again, I don't think we could, ever screen everybody who had those viruses or say that they were definitely going to cause it. It really is just an association.
And just a question from me, the protocol that you're putting together for a clinical trial is really one of the first clinical trials that'll be done for treatment of kids with IgA vasculitis, nephritis. Why do you think it's been so hard to get there? This is a relatively common disease for kids. We do probably 10 to 20 biopsies a year for kids with HSP nephritis. So the kids are out there. Why haven't we studied this before? Is it just too hard to get people to agree on a protocol?
I think there are strong feelings behind it. There are people that believe it acts very much like an IgA nephropathy type disease. There are people that believe that it acts very much like a vasculitis. But I think it's probably been neglected and suffered, perhaps because it's a multi-system disease, which doesn't quite fall into anybody's category. And it presents to our pediatric colleagues predominantly, and we end up with the more complications, renal complications. But again, it's perhaps been ignored because it's under numerous different specialties and there's been no ownership. But I also think the fact that it presents predominantly in children has caused it to be neglected, because our adult colleagues will usually lead in research, and research in children has lagged behind adults. And so I think it's probably suffered for many, many reasons. I think one of the big problems with a trial, and what we found with trying to develop a trial protocol, and what the statisticians had trouble finding working with, is this spontaneous resolution, that there are some patients who, even with severe disease, will get better no matter what we do. And so even in many of the reports, the placebo looks great. And that is very difficult to then incorporate into a clinical trial and prove that immunosuppressive agents work if your placebo looks good, because children are going to get better no matter what. So we've put together a protocol. It might not get funded, it might not be ideal, but we're a lot further on than where we were. And I think it is a common pediatric nephrology disease, and I think that we need to move, and we need to move now in the advent of all the biologic agents, because I think there will be a role for targeting more specifically the immune system through biologic agents. And if we don't have a standard management and agreement nationally or internationally, then this disease will get left behind. Yeah.
Absolutely. Another question in the chat from Tom Forbes is, the data for rituximab looks encouraging. At what point do you think it will replace IV cyclophosphamide for severe cases in the consensus guidelines? Do you know if that's updated in the new KDIGO guidelines that'll be coming out?
No, and I don't know if it will replace it. The data is really based on case series, but I do, if colleagues nationally contact me and ask for very complex cases, then I would say that there is a role for rituximab, because you get to the point where there's nothing to lose. What we're doing and what we've incorporated into the trial protocol is understanding the biology as well. So we're going to be looking at the B cell populations in the patients to try and understand if there is a target for B cell depletion. And I think if you think of it as a vasculitis, then B cell depletion is really promising. If you look at the data for IgA nephropathy, where there have been large randomized control trials looking at B cell depletion, they're all negative. And so it depends what hat you have on as to what disease you think this is. I think there is a role for B cell depletion. I just don't know whether we're quite got the science to back up replacing things like cyclophosphamide when you've got a child with severe renal impairment at the moment.
So another question from Blanche Chavers, who's one of our pediatric nephrologists. So you mentioned one of the struggles is figuring out what to treat patients with, but then the question is, how long do you treat them with? So are there any recommendations for duration of treatment for patients who have more severe disease?
Yeah, so when we did our national work and also the international workshop, there were some bits that generally nephrologists were doing similar, and one of them was duration of treatment. And most of that was once they've demonstrated they've made a complete recovery, then most people will stop, and some patients will, after only a few months or after only a small amount of treatment, they will make a complete and full recovery. And generally then, there are risks associated with these medications, and it would be recommended to stop. But on the whole, most patients were being treated for 12 months where there had been significant nephritis and there was ongoing proteinuria. Patients weren't getting rebiopsy to look for inflammation, and most people were accepting that 12 months after the acute event was likely to be sufficient to have dampened the immune process. And that was fairly standard, actually. So I think most people, if the patient hadn't made a complete and full recovery when treatment might be stopped earlier, were generally treating it for 12 months. And so our treatment trial protocol is based on a 12-month treatment course. And that, yeah, that was what we gathered from the information.
And if patients haven't recovered at that 1-year point, are you rebiopsying?
We don't, and we haven't recommended that at the moment. Yeah, who knows? I mean, I think we're not even doing that for lupus nephritis routinely in children, and perhaps there's more evidence to support the need for a second biopsy in lupus, but we're not, and that's not what's being recommended at the minute. But again, I think that we all get severe patients, and they're probably scattered amongst all pediatric nephrologists, that you never quite get a good understanding of whether we should be or not, and how long treatment should be. But at the moment, I wouldn't necessarily recommend rebiopsying. I think at that point, there potentially is a role for, if they were deteriorating, escalating treatment or considering B cell depletion. And if they're not, they're just stable, then ACE inhibition and controlling the proteinuria, backed on very, very little evidence.
And a question in the Q&A says, great talk. Is there any evidence of complement pathway activation on the renal biopsy and IgA vasculitis in children?
So yeah, we typically see C3 deposited with IgA in the organs that are biopsied, so even in the gut and the skin. And so I think there is a role for complement. The alternative pathway is suggested in the literature, and people have begun to look at that. We've got a scientist at the moment who's about halfway through a project looking at the complement pathway and looking in the urine to see if we can detect some of the markers of complement activation. And this is an area that industry are really interested in, and we're working with AstraZeneca who are interested in how we could potentially target the complement pathway. So yeah, I think there is a role, but I think the scientific data is fairly limited.
You talked a little bit about the abnormal glycosylation of the hinge region of the IgA, and we see that also in patients with IgA nephropathy, which is, for those on the video who don't see this a lot, IgA nephropathy and HSP look exactly the same on a kidney biopsy. You can't tell the difference without actually looking at the patient. So why do some patients with that abnormal glycosylation develop HSP and some develop just the renal limited IgA nephropathy?
We don't know, and it could be that there are binding areas to endothelial cells, and it could be the endothelial activation that's different between the two diseases. But we don't know, and in our proteomic work, we're going to use an IgA nephropathy control group in collaboration with Jonathan Barrett and Leicester group to try and understand if there are differences in those glycosylation patterns. And it might be that there are binding areas for endothelium that aren't present in IgA nephropathy, and so therefore they don't get the vasculitis that we see in IgA vasculitis, but we don't know. This is all speculation, we don't know. And like you said, in the kidney, they're absolutely identical, and it might be that we see identical patterns if we're looking predominantly at renal phenotypes.
And then I think the last question we have is, thanks for the superb talk. Can you please touch more on the current state of genetic predisposition?
Yeah, so there are genetic, within the literature, there are predisposition factors published, mainly involving different areas of the immune pathways. We're collecting DNA at the moment as part of an IgA disease biobank, but I'm aware of the biobank in America and the data from there, trying to look at this area too. And I don't think genetics will be everything. I think it will be a combination, like most autoimmune diseases. But whether these patients are genetically predisposed to produce this abnormal IgA would be really interesting. What we don't know is whether they're, even if they've got the genetic predisposition, why some get better and, you know, some will go on to have a persisting disease. And I think that genes might be interesting there. But I think we're far way off looking at that. We're still collecting the DNA samples as part of a biobank at the moment. We've not even thought about how to explore any of that. I think that the work being done in America is further advanced.
Well, thank you again for the fantastic overview of IgA vasculitis, or HSP, as I will probably call it for many, many more years. And good luck with your research. I look forward to seeing the results of the clinical trial.
Thank you, everyone.
Thank
Thanks.
you so much.
Bye.
Bye.
Bye-bye.